Welcome to this compression webinar brought to you by Quart Medical. Thank you for joining. My name is John Gregory and I will be moderating this recorded session. If you have any questions during the course of the presentation, you can type your question using the chat feature in your Zoom window. I think we're all familiar with that by now. I will be moderating the chat feature throughout the presentation and we will endeavour to answer them live at the end. At the conclusion of our presentation, our presenters will be available to answer your questions. I invite you to tweet away at Quart Medical or using the hashtag @EdemaWear. A copy of the call recording will be made available later today. Let me hand over to Michael Quart, who will introduce our two esteemed speakers. Michael, over to you.
Hi, folks. I was first introduced to Dr. Sibbald and Pat over 25 years ago in the preliminary discussions leading to the establishment of what later became Wounds Canada. I can remember how the focus was on train the trainer and how much work had to be done. It was soon realized that Gary had the ideas but needed the workers to put it together. He put together a team and somehow we have today thousands around the world training wound care. Gary is the founder and executive director of Woundpedia, as well as the lead of Project ECHO, Ontario Skin and Wound. And Dr. Sibbald is a professor of medicine and public health at the University of Toronto. Pat is a registered nurse with over 30 years experience in wound care. She has served on Wounds Canada board of directors and is past president of the organization. Pat herself became a trainer and was involved in this endeavor too. A great support person and a leader in her own right. Dr. Sibbald introduced me to EdemaWear back in 2016 and have been the Canadian distributor ever since. Since that time, he has conducted multiple case studies and posters of EdemaWear, including this study published in Advances in Wound Care. Now I will turn it over to Dr. Sibbald.
Okay, thank you, Michael, and thank you, John. So this session will review compression with evaluation of longitudinal and tubular compression treatment for lower limb edema. Next slide. We have received funding from Compression Dynamics, Omaha, Nebraska, manufacturer of EdemaWear. And my other conflicts of interest are really with the Mississauga-Halton Local Health Integrated Network and the Government of Ontario Department of Health and Long-Term Care. Pat?
And my conflict of interest, I echo what Dr. Sibbald said about the funding from Compression Dynamics to do this study. I serve as a member on the board of DEBRA Canada, which is Dystrophic Epidermolysis Bullosa Research Association, and the Canadian Hidradenitis Suppurativa Foundation. I'm also a board member. I do participate on a wound care clinical practice group with the Mississauga-Halton LHIN. So in this session, we hope to update you on the wound bed preparation 2021 and the use of the handheld Doppler. We would like to share with you a review of 25 patient study that we did using Edema Wear short form ELS versus Tubie grip short form ETB study. And we would like to examine low compression, both of these systems in an application technique through video.
Okay, this is the new Wound Bed Prep 2021. And it really came out of our experience in Project ECHO with situational learning of the first 100 patients that we discussed in detail with the spokes as a hub and a co-hub at Queen's University in Kingston. There are 10 components to this. Treat the cause. We want to look at arterial supply, and we'll come back to that. Etiology, modifying factors, coexisting diseases, surgery, and medications. Lots of things can modify the ability to heal. Patient-centered concerns, For patients, it's always pain, activities of daily living, and support system. We really need to look at the healing ability. Is it healable? In leg and foot ulcers, our series, about 2/3 are healable, 25% are maintenance, and about 5% non-healable or palliative. For local wound care, we need to document it, and then we need to decide on debridement. And for healable wounds, it's much more active and autolytic than non-healable or maintenance wound, where we may be looking at moisture reduction, and bacterial burden may be more important than tissue toxicity. So we come to infection, inflammation. You've probably all heard now about NERDs. Any 3 of those 5 criteria treat topically. Stonies, it's like a soup bowl, 4 criteria on the sides, 3 on the bottom. Any 3 positive treat systemically. Moisture management, we want moisture balance for healable wounds, maintenance and non-healable moisture reduction. Healing rates under 30%, if it's not 30% smaller by week 4, probably won't heal by week 12. We should start to think about that interprofessional assessment. And if it's healable, consider adjunctive therapies. And I think some of our biggest problems in wound care are the healthcare system issues. And we need to advocate for patient navigation. The cancer world is well ahead of us in wound care, and we do need system change. And this may come up in the discussion. Next slide.
So we would like to make this an interactive session. So if you could answer in, how do you want to do this, Gary, in the chat?
Andrew, yeah.
So there will be a poll. It should have already appeared. So once you vote, we'll get your answers.
Okay, so.
Okay, let them vote.
Yeah.
And we want as many of you as possible to participate in this vote. And then we will put up the answers as we go towards showing you the responses. So we're looking forward to you voting, participating. Don't forget that you can put your questions, comments in the chat. John will monitor, and we will answer in quick fire at the end as much and as many as we can. Andrew, are you ready to close off yet?
We have 75, that's 70%. We can give it a few more seconds.
Okay, anybody that hasn't participated and would like to, let's see your response. It seems as if those responses are going to be across the board.
Okay, so
all right, let's post them. And we'll show you.
Yep.
Okay.
Can you read it out?
Why don't you read it out, Andrew? I can't see it.
Okay, so the majority of the answer is 31% for I do not own a Doppler, palpate for pulses only. 23% said that they do use an audible handheld Doppler. 30% say I perform a traditional ABPI with compression of lower leg, and 18% say that they do not treat lower leg edema.
So they may actually be educators or in other roles in wound care, case managers, etc. Let's go on to the next slide. Okay, for vascular supply and healability, if you've got a palpable pulse dorsalis pedis posterior tibial in the foot, you have 80 millimeters of mercury or higher. The ankle brachial pressure index, traditionally, you have to put a cuff around the calf. You listen for the actual sound on the dorsalis pedis or posterior tibial. When you find it, you blow the cuff up. You then release it till the systolic pressure comes back and you hear the audible sound. And anything between 0.6 and 1.4, if the foot was 60 and the brachial in the arm was 100, 60 over 100.6. You'll notice 1.4 is higher than a 1.2 or 1.3. This is based on the American Heart more recent guidelines for arterial disease. Above 1.4, they're non-compressible vessels. What we want to introduce you to is using the Doppler to listen to the audible handheld signal. And this then becomes an important modality. And if it's biphasic or triphasic, it actually tells us that the audible handheld Doppler ABPI is greater than or equal 0.9. Transcutaneous oxygen measures the large and the small vessels, and the surface oxygen greater than 30 millimeters of mercury for healing. Toe pressure, you're looking at anything between 30 and 55. The more recent American Heart is greater than 30. We've often used 55 in the past. Let's look at another study on the next slide. And this is published in Vascular with Dieter Meyer of Santa Alabi, and where we listened to the audible sound, 200 patients, 379 legs. Now, it didn't mean 21 amputations. For various reasons in the vascular lab, all of them had ABPI in a gold standard certified vascular lab. When we looked at the audible Doppler, and if it was biphasic or triphasic, that means there's no peripheral vascular disease. Posterior tibial was 98.6 and dorsalis pedis 97.8%. That's awfully good for a clinical study, but you should compare that to your clinical exam. Make sure the foot's not cold. Make sure you don't have other signs of arterial disease or a history of claudication. It doesn't identify the disease, but it rules it out. So you could use your compression therapy. And if you look at that, the positive predictive value and the negative predictive value is very high. So the conclusion from this study is the audible handheld Doppler is reliable, simple, rapid, and inexpensive bedside exclusion test for peripheral vascular disease in diabetic and non-diabetic subjects. And on the next slide, we'll tell you why. And you can Google woundcarejournal.com, and this editorial and Wound Bed Prep 2021 will come up, and they are both freely downloadable right now because they are in the April, this month's edition of Advances in Skin and Wound Care. And it's a consensus of 21 experts around the world. This editorial by Dr. Elizabeth Aiello and myself, patient can be sitting in the chair. They don't have to be lying flat for 20 minutes. No pain. We're not going to blow a cuff up over the calf muscle. And it's not influenced by calcified vessel. And remember, 80% of persons with diabetes that are older have calcified vessels, 20% of the elderly population non-diabetic also. Any multiphasic, biphasic is or triphasic, and the wave results in an AHHD value equivalent to greater than 0.9 or equal. Monophasic or absent waves should trigger sequential duplex arterial Doppler in the vascular lab. And in some of the patient navigation work I'm doing with Waterloo Wellington, they can send me an audio tape from the nurse in the home at the bedside doing the assessment visit, and we can verify with the audio tape on their cell phone that it's biphasic or triphasic. Go ahead with compression. In times of COVID, we don't have to send them out to the vascular lab for the vascular studies, unless it's monophasic or absent. Next. Okay, look at this mechanism. And I think this is very important. Probably seen a physiotherapist or occupational therapist do fan taping from the malleolus. And this is a way of creating differential pressures and helping with edema control. Elastic compression, which Cochrane says is best, is from the outside in. It has high compression at rest so that if a person has a painful leg or painful edema or lipodermatosclerosis, we may get into trouble. Inelastic compression has low pressure at rest, and you only get pressure against the fixed resistance of, say, an UNA-paste boot or a zinc oxide paste boot with compression of the calf muscle. Longitudinal yarn with a fuzzy pile is Edema Wear, which gives you an up and down type of compression, but 80% of it is open space, versus Tubie grip is the characteristic horizontal cotton knit interlaced with elastic threads. Next one. And this is the traditional elastic versus non-elastic. Elastic has high pressure at rest. That may make pain worse. Non-elastic or support low pressure or no pressure at rest. With muscle contraction, elastic system has less. Non-elastic system has high compression. Low elastic is like a single layer elastic bandage or a tensor. High compression, 4-layer or a long stretch bandage. When we're looking at non-elastic support systems, you've got an UNA boot, and usually to keep it firm, you may use traditional Coban, not Coban 2, around the outside, or you may use something that's got a more even, open weave like Easy Fix. And high compression is a cohesive 2-layer inelastic system such as Coban 2. Just remember, Coban 2 only has 1 layer that provides compression over the heel. So you might want to think about alternatives if the ulcer is below the malleolus. Next one. Pat.
So we have an expert consultation here with someone who had painful legs and who couldn't tolerate compression. She's 78 years of age. She had bilateral acute painful lower legs, and that pain was increasing in severity over the last 2 weeks before she was seen. She was unable to tolerate compression because her legs were so sore. She complained of pain, which rated an 8 out of 10 on a numerical scale, and that pain was described as aching and burning. And as I said, it was worse when somebody touched her skin.
Next slide.
So what we found was that we could feel pulses. They were palpable, but we were unable to get that formal ABPI because of having to compress with the blood pressure cuff these very painful legs.
Press again.
So what we did was we looked, we had a Doppler here in the office, and we did the audible handheld Doppler on her and found that we could hear biphasic sounds with her. So we were confident that she had a good arterial flow.
Next one. Now, to comment on 8 out of 10 pain, it's better, and this has an 11-point scale because there's 0. 0 is no pain. 10 is slamming your thumb on the car door, and 5 is a bee sting. So 8 is pretty significant. Nosoceptive pain is stimulus-dependent pain. It's gnawing, aching, tender, or throbbing. And we used acetaminophen 1,000 milligrams or 1 gram 3 times a day with meals. She also had a neuropathic component, and wound pain is often a combination of the two. Burning, stinging, shooting, stabbing, BSSS. Daytime pregabalin 50 to 75 milligrams twice a day, perhaps with breakfast and dinner. And we often increase that by 50 to 75 weekly if needed and if they're not spaced out with it. And at nighttime, nortriptyline is better than amitriptyline, 10 to 30 milligrams. It's higher in anti-noradrenaline activity, which will treat neuropathic pain better. And note the bilaterally symmetrical upper boundary of the erythema and pigment and that inverted champagne fibrosis.
And just as a word of advice, these medications can be used to treat depression, and the pharmacist will very often give the individual the information about you are depressed and all that information that goes along with it. So please, if you're starting to use these medications, explain to the patient that you're not using it for depression. And Dr. Sibbald, am I right in saying that if you were treating depression, you would be using these medications at a higher dose?
Yeah, 75 to 150 milligrams.
So just forewarning, we have had people come back and say, I don't want to take this because I'm not depressed.
Next slide.
So the second question for you is up on the slide, and Andrew will start the poll. If you could please answer it for us, we would appreciate it very much.
Hasn't been, oh yeah. And you can see here the difference in the two systems. So on your left-hand side is the Edema Wear, which is an up and down weave. So it's vertical rather than horizontal. And there are many more open spaces than in the Tubie grip, which is a horizontal and a much more closed. And you'll also see both of them are turned over at the top, and that sometimes helps to prevent the rolling. How are we doing on answers, Andrew?
We have 83%, so I'll end the poll.
Yeah, and let's have a look at this. And Andrew, read us the answers.
Okay, so the most prominent answer that people voted for was that they use either Edema Wear or Tubie grip. That was 34%. 23% said Edema Wear. 33% said Tubie grip or equivalent. 4% said that they do not have Edema Wear or Tubie grip available in their practice. And 6% said that I do not treat leg edema / ulcers.
Okay, so we're across the map with either one, the other, or both. Next one. Next slide.
Yep.
Okay, Pat, go for it.
So we managed to conduct a study here within the practice, looking at both types of compression systems. This article was published in December in Advances in Skin and Wound. And is it available to them, Dr. Sibbald?
No.
Okay.
Next.
So the study design consisted of the two different products, the elasticized longitudinal stockinette, ELS, as I referred to earlier. This is a non-latex spandex component. It gives that vertical compression. It's an open net-like structure, which, as Dr. Sibbald had said, is 80% open. It does have the fuzzy wale with the skin interface, so it has causes a micro deformation of about 20%, and therefore you get your 100%. And we compared it to the elasticized tubular bandage, the ETB. In this case, it did have latex in it. There are products out there that do not have latex. It gives that horizontal compression. It is a relatively closed structure, and it is an elastic support structure system. If you, our study design, you can see the makeup of the patients. They comprised of venous disease, lymphedema, lipid factors, and arterial disease. And some people had more than one factor going on there, hence more than 100%. And if you look at the etiology of the patients, you can see that most of the people had venous disease with a compilation of the rest of the issues that go on with lower leg edema. And what we looked at for our outcomes was a change in the measurement in the circumference at the arch of the foot, above the ankle, and 10 centimeters below the tibial plateau. We also looked at the difference in the pain from beginning to the end of the study, and we asked patients to complete a preference questionnaire of which of the systems that they did prefer. Next. So our inclusion criteria, as you can see, is they had to have those measurements done. They needed to have some discomfort, and so they could report to us on pain and be willing to do that patient preference questionnaire. Obviously, they needed to have lower limbs, so if they'd had amputation, they couldn't participate, and their ABPIs needed to be between, at that point, 0.65 and less than 1.3. And the other important component was that they couldn't have any known allergy to any of the components of the compression systems, and they had to give their informed consent.
Next.
So we did have ethics approval to do this, and we had 13 participants in the unilateral edema section and 12 participants in the bilateral edema section. The patients that had unilateral edema were randomly started on either the ETB or the ELS, and then at week 2, they were switched to whichever product they weren't using in the first 2 weeks. At the final visit, that patient was asked to complete a questionnaire about their device preference. In the bilateral edema, they were started with either the ETB on one limb and the ELS on the other limb, and then at the follow-up visits, the devices were switched from left to right, right to left. What we did was we educated all the patients on the care and the application of the devices. We looked at the circumference, as I previously mentioned, at the pain scores, and they were done at each visit. And we also took photos at each visit. And these are some of the patient characteristics. It is a little hard to read, but just pulling pertinent data out. The mean age of the individuals that we saw in this study was 66. Interestingly enough, the BMI was mean average of 40.4. The range was between 26 and 67. Dr. Sibbald, do you want to comment on the common comorbidities?
Yeah, the hemoglobin A1C, 24% had diabetes, which is higher in the general population at 10%. In older individuals, increased blood pressure is common, 64% here, and increased cholesterol in 60%, heart disease in 24%. Next.
So in the end, the results of what we found, the edema reduction was not statistically significant. In the bilateral cohort, both showed a similar decrease in size at week 2 at all 3 of the measured locations. In the unilateral cohort, the ELS group had a minimal reduction, but not, again, statistically significant in the mean measurements. And in the ETB group, there was no size reduction at any of the locations. So with the patient preference, you can see that there was a clear preference in favor of the ELS group, and this was expressed in the comments that they made on the open-ended questionnaire that they could complete. It was 22% as opposed to 78% in the preference for the ELS. And then looking at the scores, there was a decrease in pain with the ELS group, as you can see from the graph that is here. It went down from 3 to 1.8. So in conclusion, both of the systems are alternatives to that traditional circumferential elastic or inelastic system for the control of edema. Both systems were easy to apply, and both provided a greater self-sufficiency for patients, and it gave them a sense of control. Both of these bandage systems have a relatively low cost compared to the compression stockings, and Dr. Sibbald wants to say something.
Oh, keep going.
Okay.
The last one.
And the ELS was preferred over the ETB by 72% of the participants. And you can see a close-up of the weave of both of these systems the ELS being at the top.
Yeah, and the ELS has fuzzy wales, or there are compressive features at the intersections, which then cause compression against the surface of the skin, differential pressure, which really helps with the edema control. Where at the bottom, you see the Tubie grip, it's more horizontal, it's more filled in. But both of these systems on the next slide produce, and if you look very carefully here at the top, you can see that you've got linear wrinkles or depressions extending down the leg. And, you know, we say to individuals that they say, oh, that's cutting off my circulation. But the answer to that is the only good wrinkles in life are the wrinkles under compression, and it shows they're working. And on the next slide.
Just before you go on with that, Dr. Sibbald, I make a point when I put Edema Wear on of putting it on, if I'm putting on bilateral legs, I will put it on one leg and then put the other on the other, of course. By the time I've got the second one on, I will roll the Edema Wear down and show the individual that they should be seeing these wrinkles or indentations in their legs, and that this is what we want to see. And when you don't see that, then it means that that product is no longer working.
And here you actually see with the Tubie grip, the lines going horizontal, if you look very carefully on the right-hand side. Next one. What does compression do? It gives you pressure under the bandage. It's sustained, controls edema, can control pain if it's properly applied. And but if somebody has allodynia or nerve pain on touching the skin, you may have trouble and you have to go slow or treat the nerve pain before you can put the compression on. Prevent new areas of breakdown, and it gives you a mechanical support. So in the Cochrane review, you're getting compression is better than none, elastic more effective than non-elastic, high better than low. And if you use multi-layers, you kind of correct for errors. And multi-layer high compression system is best suited to the patient, provider, and healthcare system. You have to see what's on your formulary. Next. Let's have a look at the video.
And just while we're getting the video up and running, I talk in the video about it being measured in inches, but it's also in centimeters. The first piece of compression that we're going to talk about is a circular elastic bandage. One of the trade names is Tubie grip. It will, when it's doubled, will give a light compression of between 10 and 15 millimeters of mercury. There is a chart that does tell you how to how to measure the leg and fit the Tubie grip. What you do is measure the largest part of the calf of the leg with a tape measure. And record that in centimeters, and according to the chart, it will tell you which of the sizes of the product is the best one for you to use to get your compression that you wish. To measure this to get the appropriate length, you need to actually start your measurement 2 fingers below the knee, giving some slack to the tube to the base of the toes. So to take this and measure the slack to the base of the toes, and this is where you want to cut it. Keeping in mind that this product does contain cotton, so it needs to be cut a little longer on the first, for the first piece. It will shrink when you wash it. It is meant to be used on a one-time basis, but it can be washed a couple of times to be used. There are several ways to put this on. One of the ways is to use a plastic bag and put it over the foot. Slip it on. For this particular leg, it measures for a size F, and holding the tube in place, removing the plastic bag. The other way to put this on is to take it, hold it back on itself so that there's enough room to insert the foot, put it on over the foot, and up over the leg. Okay. The next piece of compression that we're going to look at today is something called Edema Wear. It differs from Tubie grip in that instead of the compression being applied in a circular motion, it's applied in a longitudinal motion. It comes in varying sizes, and the leg again needs to be measured. To determine the size that one needs, again, one measures the largest part of the limb at the calf, and because it's made in the US, it comes in, it's measured in inches. So you need to be careful when you're measuring this and not measuring it in centimeters. So this leg that I've measured measures 13 inches, so it would have a small Edema Wear. There is a blue line in the Edema Wear. This is meant to be moved around with each application, because when you stretch this, you can see that the longitudinal wales, these are what provide the compression. As you move this blue line around, you then get the compression between where the wales are. There are a couple of ways of applying this as well. One of them is to stretch it out. The other thing I should say is it doesn't matter whether the blue line is at the front of the leg, the back of the leg, the side of the leg. But if you stretch it out before you apply it, stretch it out, turn it back on itself so that there's enough for the foot. And put it on. One of the issues with this is that it will tend to slip on people, and it is recommended by the manufacturer that you put a 2 to 3 inch cuff at the top of the leg, and that will help with the slippage. The other way that you can do this, which is easier for people who, if it's an older person who is applying this, and they have a bit of problems with their fingers, because this does require some dexterity with your fingers. If they're having problems, if they use a plastic bag and put it over the foot and apply the Edema Wear over it. Again, pull it up so that you've got enough to put a 2 to 3 inch cuff at the top of it to prevent the slippage. Hold on to the product and remove the plastic bag. The other piece with this, one of the pitfalls with using the Edema Wear is that the top of it will roll with use, and by simply trimming off the roll, it will help to give you a longer life for this. These are designed, if they're looked after as they should be, to last anywhere between 3 and 6 months, so they don't have to be replaced as often as some of the other types of lower compression bandaging that we have.
Okay, we're back. What have we done? We've updated the Wound Bed Prep 2021 and the use of the audible handheld Doppler, and we'd be interested in your comments in the chat. We've reviewed 25 patient Edema Wear ELS versus Tubie grip ETB study, and we've examined low compression application technique video. Next slide. So it's time for your questions. That's my garden this week. How's yours doing? The plants on the outside are Helioborus or Christmas rose. The tree in the center is a Peary's tree, and the purple plant is a primula. Questions? And John, back to you.
Okay, well, thank you to Gary and Pat for a fascinating and detailed presentation covering compression, the handheld audible Doppler, and your study in advances in skin and wound. Thank you. So yeah, there have been many questions through the Q&A. Not in any particular order. We will try and get to as many as we can in the time remaining. We are also endeavouring to finish on time. So maybe one of them actually concerns the study that you have done. You noted in one of your slides that the reduction in edema was not statistically significant. Maybe some questions from a number of people in terms of, does that mean that edema was not being reduced, that it was not statistically? Gary, can you maybe comment on that?
Yeah, your edema is unequal in where it comes. It depends on the time of day, depends how much sodium in their diet, when they've taken their diuretic, etc. So it's not unexpected. And you have to remember that this is a micro event, so that some areas are, if you like, less edema reduction and others are more. So that when you're measuring the whole area, you won't see or you will not get the indentation part. But they didn't increase, and they did get control of their symptoms. And I think that this is the way you have to remember, that it's a micro phenomena, that the two of them were equal in the bilateral thing. But there's a lot to the patient preference and to the difference between these two products. If you've got lumps and bumps and gyrations, using the longitudinal system tends to work better. You also need to make sure you go down to the base of the toes. And if patients can't tolerate higher compression, or they've got mixed arterial and venous disease, this is a much safer alternative, and it does give you some control. You can also add other layers, and you know that is sometimes a mechanism. You can go up to 4 layers of Tubie grip. With Edema Wear, they can wear another kind of stocking over top of that in some cases, if needed, and provided they don't have arterial compromise. Pat, do you want to comment?
Well, the lack of statistical significance in the reduction, it was one component of it. I think from a clinical everyday practice point of view and patient adherence, the fact that these people had the control over being able to wear something that was going to give them the compression. And this is an aside, but interestingly enough, you would show it to them, and one of their first comments was, "Oh, that looks cool. That looks like something I can handle, and my leg isn't all wrapped up." And then they would wear it and come back and say, "My leg isn't as swollen," or "I don't feel my leg is as swollen." So it was more of anecdotal reporting that showed an advantage.
That's part of it, but the other part of it is that their legs are not as tired at the end of the day as well.
Yeah.
And the edema control is only one part of what we're dealing with, as Pat mentioned, but you're also getting some highs and some lows on the skin based on the structure of these two products. John, back to you.
Just
yeah, no, thank you. Yeah, I mean, the only other thing I was going to say is statistical significance is also dependent on both the study design and the objectives of the study. Sorry, Pat, you were going to add something else in.
Well, just by starting people with this particular type of compression, for people who needed, that weren't getting optimal control, we were actually able to move them up to one of the other types of compression. And then their maintenance went back to wearing the Edema Wear because they were familiar with it. So it was a bonus for everyone around. We could say to them, let's compress your leg a little bit more, see if we can get the edema down. And they were very pleased that they went from one size of Edema Wear to another, to a smaller size of Edema Wear after the compression.
Yeah, thank you, Pat. Not unsurprisingly, not much interest both in the articles that you described, or actually 3 articles that you described, particularly around measurement of ABPI. Now, Nitin had asked, what if ABPI is 1.94? What kind of intervention is preferable for those patients?
Well, if it's 1.94, it means there's non-compressible vessels, and you should get out your Doppler and do an audible handheld Doppler, because the biphasic and triphasic sounds are not dependent on the calcification, but your ABPI is. So this gets you over that. So this is the perfect situation in which the audible handheld Doppler will work for you. And if you're not sure of your sound, record it.
Yeah, and on that point, actually, Gary, I did my IIWCC selective on ABPI many years ago now. And actually, a number of people have said, is it possible to get either YouTube links or links to what those sounds like? I know you have them. I have them too. I'm sure that's something we can share.
Okay, let me give him the answer. Dieter Meyer, who, with Evsen and myself, kind of devised that. And Dieter Meyer's a vascular surgeon. He used to run the V Symposium, the wound care part of the International Vascular thing. And on the advances in skin and wound care, there's a 15-minute video with Dieter illustrating all those sounds. So from the horse's mouth, the senior author on that article, and Dieter will take you through it, and you can go and listen to it.
Okay, well, I'll get a link from that in the email together with the recording. We will highlight that and draw people to it. So Alison was talking about the fact they use Doppler ability policies to do ABPI before compression. That's fantastic. But she says it sounds like checking pulses with a handheld Doppler would be sufficient. That
is correct, but you're not checking pulses, you're checking the waveform. A pulse is really present or absent. Just make sure that you say it's a waveform and that you record it. The only thing is the biphasic or triphasic waveform is adequate. If it's monophasic or you can't find it, you really need a full duplex arterial Doppler in the vascular lab, because you need to know if it's bypassable, dilatable, where the actual constriction of the artery is. Is it proximal? Is it distal? Is it bypassable? Is it dilatable?
Yeah, thank you, Gary. Pat, question for you from Christine, and actually a great number of people, either noticing the compression folded over under the knee or 2 layers. Can you comment on that? There seems to be some misunderstanding or interest in learning more about that in terms of, is it contraindicated? Is that okay? And in which patients would you do that?
I'm not sure I'm totally understanding the question. Your compression should stop 2 fingers below the back of the knee in the popliteal space.
What they're asking you is because you fold it down.
Yeah.
Okay, yeah. But that's at the widest area when you get up above the knee. And the second layer is really relatively loose to the first one. So it's not as if you're putting another extra layer of an elastic system with high pressure that you're putting on just below the knee. And you can actually monitor that yourself by looking, or you can pull and see if there's extra pressure there. And if there is, you can cut, a little bit of that upper layer so there's not pressure. But we have very seldom, if ever, come into that problem.
Yeah, so this is not the same principle, I guess, as when you're doing a bandage wrap. Certainly,
especially elastic.
Yeah, you don't want to increase the layers in any of the bandage systems at the 2 fingers below the knee, the back of the knee. You want only 1 layer there, but because these work in a different mechanism, that turning it down is not going to get that effect that you would get if you did the bandaging that way.
Correct. And I think it's more equivalent to the short stretch where you can go up and down, or the non-elastic systems.
Yeah, no, absolutely. Thank you. Yeah, I mean, there's been follow-up questions about, does it create or is there a cause for concern around a tourniquet effect? I think, you've just kind of dealt with that as well.
But look at the leg and pull it down, and yes, you'll see what'll happen when you do that is you'll get a wider band at the top, which is great, so that you don't get, a constrictive band in one spot right at the top. It kind of makes that top band expand a little bit.
So as recommended, you're to put a 10 to 15 centimeter, 2 to 3 inch cuff at the top. The other piece, just talking about putting the cuff there to help stop it from slipping. If it does slip, what we have found clinically is if you put it on inside out, it will stop the edema wear from slipping as well. But certainly with all of the people that we have used, a tourniquet effect has not been one that people have reported to us and a reason why they wouldn't wear it.
Yeah, thank you, Pat. A number of other people have suggested about using it inside out, and actually the question of sizing, both for whether it be EdemaWear or other products, has come up. I think we know that correct sizing is quite important. Maybe Pat, can you speak to that?
Well, it is very important, and it is important to, it doesn't matter which of those systems you're using, it is important to follow the manufacturer's guidelines that one is given, so that you are getting what the manufacturer is intending you to get compression-wise. So measuring the largest part of the calf will give you the appropriate measurements. And the manufacturers all provide good guidance about how to use their products. So if you're not sure and you are a clinician, I would suggest that you do some investigation on the manufacturer's websites or talk to the representatives, because they're all very, very helpful.
And John, just I'm reading the EdemaWear small. It says limb circumference up to 45 centimeters, and then in brackets 18 inches. Okay, when you look at the insert with the product, but again, you could get the small, medium, large, extra large,
and light.
And we can make those available to people afterwards. Link particularly about EdemaWear, but Pat, taking your suggestion in terms of it's important to follow the instructions for use from different manufacturers.
And your Tubie grip has recommendations for B through J.
And they are all accessible on the manufacturer's websites.
Okay, John, next question.
Next question is, it continues to be a number around, I think, there's certainly an inequality around access to ABPI. Holly's talking about, that only physicians in her practice area, sorry, Holly, I don't actually know where you are in Canada, create, I think, some issues. There's can you repeat the explanation about the calcification and audible handheld Doppler?
Yeah, okay. So that what I'm saying, and you know, this is important where there may be long waiting times for vascular labs, or say in Northern Ontario, where you would have to fly somebody out from a remote area to a vascular lab. So the calcification issue is that if you've got a calcified vessel, you cannot adequately squeeze the vessel to get an accurate ABPI.
With a blood pressure cuff.
With a blood pressure cuff. So that's why the blood pressure cuff will not squeeze the vessel, because there's calcium. But the vessel still can transmit the waveform. And the waveform is really how the blood goes down to the periphery. And so that when you use the audible handheld Doppler, you're listening to the waveform, not just the presence or absence of it. You're listening to the waveform. And we've shown that what we did in that study was all 200 patients, and that's 200 patients. All of them had vascular studies in the Trillium Mississauga Hospital site vascular lab. And we knew their sequential Dopplers, and their sounds were independently assessed. And if they were biphasic or triphasic, calcification doesn't stop a biphasic wave, or it doesn't stop a triphasic wave. It just means you can't squeeze the vessel, so you can't do a traditional Doppler. And a traditional Doppler takes 20 or 30 minutes. This you can do in 1 minute. And it can be done with the patient seated. Just be careful you don't put too much pressure on it and you're dampening it. It should face up towards, you need enough gel, and you need to gently just put it on the surface. If you press it, you may suppress the triphasic or the biphasic wave. But if you just put it on gently, and it doesn't take much practice if you've been doing a traditional ABPI, and it's just to get familiar with the sounds. And I think listening to that video, and some of these questions came up in the question period. Dr. Alavi and I were in the audience in Abu Dhabi when we recorded this. So it really is worth listening to that. And that's part of the 9 skills videos that we have with Project ECHO and the International Interprofessional Wound Course, which next edition is in September, John, that, you know, they have 9 skills videos, and you actually watch the videos. And because of COVID, we had to go to this because we couldn't have boot camps with the skills. And, you know, that video is part of those video series, and where you listen, and then you're going to record your own video, or you're going to listen to recordings and decide if it's monophasic, biphasic, or triphasic. And monophasic is just biphasic is and triphasic is and if you listen to Dieter, he's even better at it than I am.
I find that hard to believe. You've had a lot of practice, Gary. Corey has been asking about ABPI, and particularly some of the kind of new research. I don't know if Corey is able to kind of jump in and maybe ask the question himself. Sorry, I was trying to get Corey off mute so that maybe he could pose the question himself. But anyway, he said the change from ABPI of less than 0.5 to less than 0.6 as being indicative of non-healing wound. I was unable to find any discussion of the ABPI less than 0.9 in the AHA guidelines and the Wound Canada guidelines. Still talks about 0.5 as non-compressible. Gary, can you speak to that? Obviously, you understand quite well.
0.5 doesn't mean non-compressible. It means that you've got low arterial circulation. The reason that we use 0.65 and 0.6 is that we're worried in those transition areas, and it may reflect a little bit of calcification. We're just worried in that zone that we may do more harm than good, and we really want them to have a full vascular assessment in the vascular lab. But if you could hear a biphasic wave, then we would be okay with you putting compression on those people because we know the ABPI is greater than 0.9. Monophasic could be anywhere up to, say, 0.8, so that, you know, it's not that discriminatory and you've got mixed disease. But a little bit of the problem is, yes, Corey, there could be some calcification, and a real 0.5 comes through at 0.65. That could happen. And no, there isn't a lot of good literature around that. And I think when in doubt, they need a full arterial assessment in the vascular lab. And I would be much happier. And this is where we're comfortable at 0.6 rather than 0.5. We don't want you really way down at the borderline and not knowing how much calcification is there. We really want those people going to the vascular lab. And you know, that's only one part of what you're looking at. You should look at the clinical characteristics. Is it cold or warm? You know, do they complain of claudication? What is the circulation time? If you press your finger in, within 3 seconds, the whitening should become pink again. So you want to look at the patient and not just rely on one number, but that's part of your assessment. And can you feel the pulses or not? And that's, you know, another component that you can look at here.
Yeah, thank you, Gary. Sorry.
I just want to say we chose 0.65 as the low end for the study for the exact reason that Dr. Sibbald was talking about. We were trying to avoid anyone who may have an arterial problem. So that 0.65 in the inclusion criteria was
it's a comfort zone,
yeah.
More than anything else. I mean, yes, you'll usually see 0.5, but those people between 0.5 and 0.65, if that was my mother or my grandmother or my mother-in-law, I probably really want them to have a vascular study.
I'd like to thank you for joining today's session with Dr. Sibbald and Pat Coutts. Thank you for Andrew Moyen in the background on behalf of Woundpedia for helping with this webinar. We hope this will become the first in a series of webinars exploring compression. You will receive an email later with the recording, which you will be able to share. Have a wonderful rest of your day and stay safe. Thank you very much for being here.